Good afternoon, everyone. My name is Maya Luria with TMC for Seniors. And today we are going to be talking all about stroke. This is Think Fast, Stroke Signs and Symptoms. I have Dr. David Teeple here with me. He is our TMC Stroke Director. He is also with Center for Neurosciences. How are you today, Dr. Teeple?
I'm doing great. Thanks.
Yes. So I love when you come. You are always very excited to share with us all about stroke, what we need to know. So I'll go ahead and put your PowerPoint up. We do have an online audience that's watching along with an in-person audience. So if you're watching from home, please feel free to enter any questions into the chat and I will ask Dr. Teeple afterwards. I'll turn it over to you, Dr. Teeple.
Awesome, guys. All right. Thank you. Thrilled to be here and excited to talk to everybody today about stroke and the brain. The brain is so fascinating. People always ask me why I went into neurology, and I tell you it's because I can't imagine thinking about anything as much as I had to think about my work, and it has to be something exciting, and the brain is the most exciting thing about the human body, in my opinion. And hopefully I can share that with you guys, and in the process, teach you a little bit about stroke, and at least how we approach stroke and the things you need to know. If you can't hear me, let me know. I tend to walk around a little bit as I go. And so if for some reason you lose audio, let me know. And with that, we'll just jump in. So we're going to talk today about what exactly a stroke is. And then I want to give you guys a little bit of neuroanatomy, which is, to me, is the most fun part of neurology, is the brain and the anatomy of the brain and everything that the brain does. And but I think in this case, it particularly helps in understanding why the signs and symptoms we talk about for stroke, why we talk about them, and then what we do as far as stroke treatment goes. So first, what the heck is a stroke? And the problem with defining stroke is that when we talk about, well, just as an aside, why is a stroke called a stroke? Anyone know? I mean, a heart attack makes sense, right? A chest pain is a heart attack. Why the heck is a stroke called a stroke?
Different strokes from your blood.
Different strokes for different folks. And so it ultimately is an old, notion from the Dark Ages that people who had strokes were actually being smited, maybe the right word, by the hand of God. It was the stroke of the hand of God for something they did wrong. And people deserved it. And to this day, that term still, we use it. I mean, it's kind of really fascinating. And it's, it has nothing to do with, we tried to change the name of stroke to brain attack, cerebrovascular accident, CVA, but everyone still just calls it a stroke. So kind of fascinating. So what's confusing about stroke is that we talk about three different entities when we talk about stroke, and they're all labeled stroke. Okay. The first one is something called an ischemic stroke. Okay. And an ischemic stroke is the most common type of stroke. And that's where we have a blood clot that travels up an artery, blocks an artery. And then everywhere that artery goes is now all of a sudden not getting oxygen. When it doesn't get oxygen, that part of the brain stops working. And we get symptoms, facial droop, arm weakness. And quickly those brain cells start to actually die because they don't get enough oxygen. So this is an ischemic stroke, a blood clot blocking an artery. The second type of stroke that people get, or the entity that I guess we call stroke, is an intracerebral hemorrhage, okay, bleeding into the brain. And so in our brain, we have these big arteries or carotid arteries. They go up into your brain, and off these arteries come these little fine, feathery, wimpy arteries. And essentially what happens is things like high blood pressure. Well, the big arteries can handle that, but these little guys, they wimp out. And at some point, they can rupture and bleed. And when that happens, you bleed into your brain, and you get this intracerebral hemorrhage. It tends to happen in very classic parts of the brain. And so this is the second entity that we'll call a stroke. Sometimes people will call it a hemorrhagic stroke. These little arteries rupture. And then the third, least common, but most dangerous type of stroke is something called a subarachnoid hemorrhage. And a subarachnoid hemorrhage is where you have a small aneurysm in your brain, okay? Aneurysms cause no symptoms when they're just sitting there. People cannot feel an aneurysm. I've seen these humongous aneurysms in people's heads, and they feel nothing. The problem is, if that aneurysm ruptures or pops, into the brain, then it causes symptoms. And what it tends to do is it bleeds around the outside of the brain. So it's interesting, if I show someone a CAT scan of a subarachnoid hemorrhage, which is what this is, you can barely see anything. But the symptoms are pretty profound. And the symptoms are sudden onset of the worst headache of your life. I had a patient once describe it to me, which I thought was, it fit. He said, "Doc, it was like someone came up behind me with a baseball bat and hit me as hard as it could, whack, in the back of my head." So it is not a subtle thing. It is catastrophically bad, sudden onset, worst headache of your life. The least common type of stroke. So we see roughly about 800,000 new strokes a year in the US. And out of those strokes, the vast majority, almost 90%, are ischemic strokes, blood clots to the brain. About 9% of the intracerebral hemorrhages, and then 3%, a tiny amount, are the ruptured aneurysms or the subarachnoid hemorrhages. So, what are the signs and symptoms of stroke? And so backing up, actually, I think important to recognize, because the ischemic strokes are the vast majority of strokes that we deal with, this is the majority of what we're going to talk about, okay? To some degree, this applies also to hemorrhage. The subarachnoid hemorrhage is such a unique thing, right? Sudden onset, worst headache of your life, that's a separate entity. So really the vast majority of strokes we're going to talk about are going to be the ischemic strokes. And when we talk about the signs and symptoms, that's what we really are talking about. And so to understand the signs and symptoms of stroke, I think we just need to get a little bit of neuroanatomy, a little bit of the brain. And so we're going to talk about it. First of all, it's the brain, right? We look at it on the surface and it's pretty interesting, but we have actually a really cool mode to look at the brain, and that is an MRI that's called diffusion tensor imaging. And when we do that, we can begin to see the tracks in our brain. And while the brain is amazing to look at, when you see the tracks, you begin to realize, holy Moses, the brain is a complicated thing. Roughly about 100 billion brain cells, and each brain cell, with multiple different, dendrites and axons going different places, the connections are mind-boggling. I think this is a beautiful picture. So if we back up, so this is, if we look this, we have this head, and we take away the skull, this is what the brain looks like, right? Eyeballs would be over here. And in the brain, we've got the frontal lobe, the parietal lobe, the occipital lobe, the temporal lobe, the cerebellum in the base of the brain, and the brainstem. And each of these does a different thing. The frontal lobe is involved in your personality. And you guys heard the story of Phineas Gage? Yes, no? Okay, we're going to tell you. So Phineas Gage is a great story about what your frontal lobe does. So Phineas Gage was, he worked on the railroads in the 1860s, give or take, and in the East, as they were building the railroads, what they would do to get through rocky terrain and keep the railroad going is they would drill holes in the ground, put a stick of dynamite in this giant stake in there, and it would blow up and it would rip through the ground and tear out the rock, and they could keep building the train tracks. And Phineas Gage was on time, perfect, model worker. Maybe he was the boss. He was awesome. And one day he was in the wrong spot at the right time, at the wrong time. One of those blasts went off. The spike went through his head, underneath, just above his eye, through the top of the skull and out. And he lived. But his personality fundamentally changed, and it became this foul-mouthed drinker, never on time. Kind of like me now, but no, a guy, and it completely changed his personality. And we see this, right? People get frontal lobotomies, right? And so a couple things can happen. It's the part of your brain that's it's your internal, monitoring. No, I shouldn't say that out loud. I shouldn't do that here. I shouldn't. And it's also part of what though makes you, want to do things and please other people and be on time. And so people with frontal lobe injuries, it just has a huge fundamental change to their personality. Sometimes people can become what we call abulic, which is they just don't want to interact with their environment. They come and sit in my office, and they'll just sit there. And if I don't talk to them, they'll just sit there and not do anything and be perfectly happy. wives or spouses of these patients can be pretty frustrated sometimes because they're like, he's not doing anything. On the flip side, people can become terribly disinhibited and say totally inappropriate things at the wrong times. And that's all frontal lobe kind of activity. You probably lots of people you think, oh gosh, I wonder what that guy's frontal lobe is like, people friends. Anyway, next, muscle strength. So the back of the frontal lobes are enormous, by the way. If I could show you a real brain, the frontal lobe goes like that to here, really, and the parietal lobe is not nearly this big. This is how it's drawn in every anatomy textbook you'll ever see. But a real brain, it sort of floor you how big your frontal lobe is. And because these personality issues are really big, but there's also a big component at the back end of the frontal lobe that controls your motor function. Okay, so all of your primary and motor neurons are at the back of your frontal lobe. We'll talk about that more in a minute. The parietal lobe, just behind the frontal lobe, is the sort of sensory integration part of your brain. So that's where all the senses, right? Touch and feeling, pain and temperature, all that stuff is coming into your parietal lobe and you're assessing it. So people with parietal lobe injuries, they're interesting. Often they'll have sensory loss, but often they'll have something that's a little bit weirder. And so a very common thing you see with parietal lobe injury is something called neglect. And neglect isn't necessarily sensory loss. Neglect is just all of a sudden, you just don't pay attention to things on that side of the world, And so people, person with neglect, you ask them to draw a clock, and they may draw one half of the clock perfectly, but not the other half. Or, in extreme circumstances, shave half the face, or put on one sleeve but not put on the other sleeve. There was a famous story they used to tell when I was in residency of this patient who kept had a stroke. I was in the hospital, and they would keep falling out of bed. And they were like, what is going on? Why do you keep falling out of bed? And this guy would say, there's someone in my bed. I don't know what you're talking about. There's someone in my bed, and I threw him out. And they watched him, and this guy had such terrible neglect. He didn't recognize his own leg, and would push it out of the bed and fall out of bed. And there's a thing called alien hand syndrome, right? And I've seen it with my own two eyes. Someone has a parietal stroke, and on the opposite hand, whose hand is that? I don't know. I think it's your hand. Here's my hand. Here's my other hand. Whose hand is this? I don't know. I think it's your hand. It's your hand. No, it's not. It's not my hand. And sometimes they even can't control it, and it'll do stuff that they can't control. So the parietal lobe is very interesting. There's a spot in the parietal lobe on one side of the brain that if you have a stroke there, you'll get something called Gerstmann syndrome. And so what is Gerstmann syndrome? Gerstmann syndrome is a syndrome where you suddenly can't count. You can't add and subtract 2 plus 2. I don't know. You can't figure out which finger is which. Okay, show me which one's your index finger. I don't know. What's your ring finger? I don't know. There's a part of your brain that's involved in knowing which finger is which finger. And the other thing, they can't figure out right and left differentiation. They can't figure out right and left. That's just one spot in the parietal lobe, typically in the right side of the brain. I find that fascinating. And like if you see a stroke there, and people don't ask those specific questions, but you ask those specific questions, you see it almost every single time. The occipital lobe is vision, right? So it's kind of interesting, right? The information from eyeballs, vision comes into the eyeballs, hits your retina, goes to your optic nerves, and then in your optic nerves, it goes all the way to the back of your brain to get processed as vision. Interesting. I don't know what the guy upstairs was thinking exactly when he did that, but it's the back of our brain. The cerebellum is a coordinating organ. And so interestingly, about 80% of our neurons, so I find this actually somewhat disappointing. 80% of our neurons are in the cerebellum. Okay, not up here in our personality and our thinking, they're down here in the coordination part of our brain. And so what does the cerebellum do? So if I want to grab something, I'm coordinating all the different muscles of my body, right? My lats and my shoulders and my biceps and my triceps to make this smooth pathway to pick something up or to punch somebody or to do anything, to type. And so the cerebellum is what coordinates that. So when people have a cerebellar disorder, the motions are off. The movements are all there. They can do all the different muscle movements, but they're not coordinated in a nice, smooth fashion. So if you watch them try to reach for something, they're all over the place as they go. That can happen to the trunk and cause balance issues with walking. That can happen with gait. And in fact, the part of your brain that you disinhibit first when you are intoxicated with alcohol is the cerebellum, right? So people talk about staggering around like a drunk. That's cerebellar dysfunction. The temporal lobe is my favorite lobe. I don't know if I have a favorite, but I do like the temporal lobe. And so by and large, that's the lobe involved in memory, okay? Short-term memory in the temporal lobe on the midline. So if I could just go straight in, sort of behind your eye and just above your ear, that's your temporal lobe. And on the midline side is something called the hippocampus. The hippocampus is your short-term memory structure. That's the first area that starts to show damage and atrophy in Alzheimer's disease. The temporal lobe does other stuff though, and I'll show you things. There are parts of the temporal lobe and the frontal lobe also involved in language, but we'll talk about that later. But that's a rough tour of the different parts of the brain. When it comes to how our bodies are mapped in our brain, though, it's really interesting, and a lot of this work stems from this guy, Dr. Wilder Penfield, and he's a fascinating neurosurgeon from who trained actually in New York and then started the Montreal Neurological Institute, and he did pioneering work on epilepsy surgery of all things. But one of the things he was really fascinated with was mapping out, important parts of the brain that he didn't want to cut out. And so he did this. He pioneered brain mapping in patients who are awake during surgery. And this was actually in the 50s and 60s. He died in 1976. And you can see this is Wilder Penfield, one of these guys, probably that guy or that, probably that guy, and this guy who's awake in the operating room. And what he would do is he would expose the brain, and we do this today in a shockingly similar way. Expose the brain, and he would put grids on the brain, or have this little pen that would essentially generate a very mild electrical charge, and he could touch it, the parts of the brain, right, and see that okay, there's the face, there's the arm, there's the leg, and mapped out the motor and sensory parts of the brain. And while this varies to some degree, there's a general pattern here that fits pretty well.
So he's removing the skull.
Yeah, so this would be during brain surgery. He would take off the skull, expose the brain, and say, okay, the notion was, they were going to do surgery on him, right? And so before that, he would wake them up and test things out. Yeah, and so you could have them, once the brain is exposed, things that cause pain are much less. And so you can have someone wake up in twilight, I don't know that I want to do it, but we do it. What we've done, actually, just as an aside, so mapping out is actually really important, like in epilepsy surgery. And so what we tend to do today in cases is we'll put a big, huge grid over the brain that we think needs to come out, and it's a grid of electrodes with maybe 50, 64 electrodes on there. And then put the skull back on with the electrode, with the wires coming out, and then bring the person to a room and actually monitor them for a couple of days. And you can actually activate each different electrode there and map out, like, okay, this is hand, and this is face, and this is arm, and then guide the surgeon as to what you cut out, what you don't cut out. But what Dr. Penfield found was this sort of general pattern in people's brains, which you and I all have, which is we have our body mapped in our brain. In the frontal lobe, you have motor, the primary motor neurons, and in the parietal lobe, you have the primary sensory neurons. And there's a place where there's your lips and your eyebrow and your hand and your elbow. And then interestingly, like the legs always hang over the side. So I can tell if someone has a stroke in this area, even before I see them, that person's gonna have a weak leg. I can tell when they have a stroke right here, that person's gonna have a weak hand. And you see how the hand and the face are right next to each other, okay? And I point out the hand and the face, arm and the face, they take up a huge amount of your brain. The amount of neurons that are devoted to making your face move and your hand move coordinate is immense. And we'll come back to that. That's an important sort of factor to be aware of. Another interesting thing, right, is the fact that our brain is crossed, right? So the right side of your brain controls the left side of your body. The left side of your brain controls the right side of your body. Anyone in here left-handed besides me? Who's left-handed? Yeah. All right. Okay. If the right side of the brain controls the left side of the body, then only left-handed people are in their right minds. Remember that. The world beat us down all those years in class, and those left and right-handed notebooks and chairs. Now, the left and the right sides of the brain, there's sort of this notion of like, there's the artistic side and there's the science side of the brain. I don't know that that's really something that's been very well proven in any literature, but there is definitely an important difference between the left side and the right side of the brain. The left side of the brain is really, really important for all right-handers and the majority of left-handers. And the reason the left side of the brain is important is that that's where language is located, right? And language is a fundamental part of what makes us us, okay? And by language, we talk about, well, you hear something or you read something, your ability to comprehend what you heard and read, be able to process that for what it is, and then generate a response, and then have that response come out. And when you can't do that, there's a lot of the humanity is lost. And so how does that look? So that is in over 95% of right-handers, and I can't remember, 70% of left-handers, something like that. The language architecture is in the left side of the brain. And so what you have is an area in the temporal lobe called Wernicke's area, named after Karl Wernicke. And Wernicke's area is where language comes, written and auditory, where you comprehend what people said or what you read. You synthesize, and then what happens is then between Wernicke's area and into that parietal lobe, that integration area, you finish understanding it, generate a response, and then it goes to the information then gets transferred down to something called the arcuate fasciculus, to your frontal lobe, Broca's area, which is where you generate your spoken word, okay, what I want to say. And so when people have injury to Wernicke's area, they can't understand anything. They can't understand what people say or what they read. It doesn't make any sense to them. But they can say all kinds of stuff, usually somewhat lacking content. And then people who have injury to Broca's area, they understand everything perfectly, but they can't speak. They're mute, or they're very limited in their outward production of language. So the left hemisphere of the brain is very, very important. Okay. So then let's take this and let's jump to what are the signs and symptoms that we look for. And we use this acronym called B.F.A.S.T. And so B.F.A.S.T. is it's the most useful acronym that we've really come up with to kind of catch the vast majority of strokes. Notice I did not say catch every stroke. It is, I would kill for an EKG or a blood test or pain most of the time as an indicator for stroke. Strokes are so hard sometimes to catch because they don't hurt. The vast majority, 3% hurt, 97% don't hurt. And ultimately, right, your brain does everything. Everything. So that means anything can be anything. And so we'll get back to that in a minute. So, but by and large, B.F.A.S.T. covers the vast majority. So first, B. Okay, this is an acronym that we're using to identify stroke symptoms. Balance. Okay, sudden loss of balance. This has to do with cerebellar injury. Okay, And people will suddenly be staggering around like a drunk. People describe like I just lost my balance. I couldn't, felt like the world maybe went to the side, or I just couldn't balance myself. Sometimes people can. One of the ways we test this, people don't often appreciate this, but we'll do something called a finger to nose test, right? Like a sobriety test. And people who have, will be able to see. You take the good side, and they're perfect. Okay. You do the bad side, and they're like, oh, I can't do it. And so this finger to nose test can be very helpful, but these are patients that are sometimes hard to catch because why? Their strength may be perfect. Their sensation may be perfect. Their language may be fine, but this person has a debilitating stroke symptom, which is they can't walk. And that has a huge impact on their ability to function. So this can be a little tricky sometimes to catch. It's interesting, we have a very well-known stroke scale that we use called the National Institutes of Stroke Scale, NIH Stroke Scale. And we use it worldwide, certainly nationwide, as like a way that we measure stroke severity. Nowhere on that do they ever ask anybody to get up and try to walk. It's very interesting. And so these symptoms are missed. So balance, sudden loss of balance. By the way, vertigo, which is the symptom of spinning or movement, not necessarily spinning, but movement when you're not moving. That can be a sign of a stroke. I would point out it is a rare sign for a stroke, and vertigo, almost the vast majority, 96% give or take, is actually due to usually something in the inner ear causing spinning sensation. It makes people miserable, they're vomiting, they're throwing up, they can't function. It's an awful symptom, but rarely a stroke, but it can be. Often when vertigo is a symptom of a stroke, it's also, there are other things involved. Sensory loss, weakness, double vision, something else. Okay, balance. Next, eyes. And so typically when we talk about eyes, we talk about sudden vision loss, okay? And the way that the vision works in our brain, if there's a stroke of the occipital lobe, the way vision is lost is very sneaky. It looks like this. Someone loses vision on one half of the world, and it tends to involve both eyes perfectly evenly. And what makes this even trickier sometimes is that this type of vision loss, well, when you look at it this way, you think, holy cow, that would be pretty obvious if that happened to me. People who have this don't appreciate this vision loss. There's often a sense of neglect, like I talked about. It is rare that I see someone with this type of vision loss, and that's their primary complaint. They may say, something's not right. I feel like I lost a little bit of my peripheral vision. That'll be like the type of thing you might get. Or more often it's a spouse who says, he's walking in the wall, something's wrong with that guy, check him out. And what I'll do always, I'll have people look at my nose, and I'll kind of flap my hands on either side, and usually if you can see fine, the look I get from my patient is, you're crazy. Both hands, what are you doing, man? And the person that can't see points at one hand, and usually until I get right in front of their nose, they're like, oh, there's the other hand. And it's pretty profound and just very frequently missed by the patient. The other way that we can lose vision is this. And this, this happens usually when you have carotid artery disease, but sometimes it can come from the heart. And if the carotid is sick, it can send little plaques of cholesterol up the carotid, and off the carotid comes the central retinal arteries. The artery to our eyes comes up our carotid artery. And so a little piece of plaque can sometimes go through the retina, the retinal artery, and go into the eyeball. And what you'll tend to get is this vision loss that tends to be altitudinal, meaning it'll come down like a curtain or up like a, reverse curtain. It doesn't tend to come, it doesn't tend to do this. It tends to be top to bottom, and it tends to be painless. And often what will happen is that plaque will come through and go away. And so many people, that kind of vision loss lasts for a minute and a half, 30 seconds. There's no pain. And they're like, that's weird. And then they don't tell anybody. And so the idea is this painless vision loss in one eye is always just go to the ER. If you go to your ophthalmologist is going to say, go to the ER. Because you need vascular imaging of your neck to make sure the carotids are okay. You don't need carotid surgery. And then you need an EKG to make sure your heart looks okay. Tricky because it's painless. One thing I didn't put on here, but I would accept is true. Double vision would be another one that I would have on my radar for vision changes. A little bit less common with a stroke, but can definitely happen. And so double vision would be another one. Interestingly, double vision, when it's coming from the brain, has a unique quality, right? And that is that the way that you have your single vision is your eyeballs are moving in perfect unison, right? And your brain has become very adjusted to how you're getting those images in. If one eye doesn't move right, then you're getting two different images sent to your brain. Your brain says, blah, and you see double. And so what's unique about a brain cause of double vision is if you cover up one eye, it should totally go away. If one eye's covered, if you have one eye covered and you still have double vision, it's not your brain. Then it's a refractive issue with the lens, something else going on in the eyeball itself, and that's something you need to see your ophthalmologist for. Face. So, does this guy have a facial droop?
Yeah.
Heck yeah, he has a facial droop. Is this guy having a stroke? What's that? Had a stroke. And so I see this guy and I say, phew, you're fine. I see this guy and I think, oh, crud, we got a problem. So what's the difference? So this guy's he's smiling on the side, no smile over here, but his brow is pretty symmetric, okay? I go to this guy, okay, he's clearly got a facial droop over here, but he's raising this eyebrow and this eyebrow is not moving at all. This is a Bell's palsy. And so interestingly, when you have a stroke will affect your brain, your face from here down. But it doesn't affect your brows because you have bilateral, God knows why, only God knows why, but your forehead is bilaterally innervated. So if you have a stroke on one side, the mouth will become weak, but the brow is nice and symmetric on both sides. And so this is a peripheral nerve injury that happens to some people, and it can be disfiguring and really frustrating, but it's not stroke. And that's the key, the forehead. And so look for an uneven smile. And what I look for is these cheek, your dimples, and we call that the nasolabial fold. How even does this look? And that's because sometimes the asymmetry is a little subtle. And so when you look here, you can begin to see, some people will count teeth across. We don't all have teeth. That sometimes is helpful, but really kind of comparing this fold to that fold, usually that's when I can see, oh, yeah, there's definitely, that one's blunted, that one's flatter, and that one's nice and creased. Next, arm weakness, okay, and especially hand weakness. I mean, you saw, the picture I have, which I think I have again, but the face and the arm are hugely represented in the brain. So face and arm / hand weakness go hand in hand. The face and hand are very close to each other in the brain. So typically if someone has hand weakness and arm weakness and no face weakness, I'm a little skeptical. Anything's possible, but I become a little bit skeptical that it might not be the brain. Typically the way that I'll look for hand weakness, and this picture is not the world's best, is I'll actually have them hold their hands out like they're holding up soup bowls. I used to say, if I put your hands out like you're holding up a pizza box, I always want pizza. Often I'll have them close their eyes even. And what you'll see when people are weak on one side is the hand tends to turn and it'll go down. But the first thing we'll see is often the hand will come up like this and turn over and then be weak like that. And again, that's, but testing, you can have them grip your hand, push, pull if you want to. But arm weakness and face weakness, I'm really, really worried. And again, what we have here is that in that homunculus, and this is the way all of our brains look, it's really fascinating. There's a spot in the brain, I can tell you, like if there's a stroke in that spot, that is the hand in everybody. It's called the hand knob. It's like right there. I think that is the hand knob. But so the face and the hand are hugely represented in the brain. And so we talk about face and arm weakness when we talk about stroke symptoms. The frustrating part is, can you have weakness just of your tongue? Could you have just swallowing problems? Could you have leg weakness that's just leg weakness? The answer is you can. Those are just much less likely. And there's typically other causes for those types of problems. we talked about speech, and so just one, so backing up, right? So be fast, balance, eyes, face, arm. The S is speech, okay? And speech and it doesn't really, I guess, matter very much which of these two things it is. I talk about it because I just find them interesting, and it maybe has some value in sort of understanding. But when we talk about speech, there are two things that we worry about. Slurring of the speech or dysarthria and aphasia. And so slurred speech, I could have sworn I put a picture of a gal with a mouthful of marbles somewhere on here. And so speech or slurred speech or dysarthria is the apparatus in your mouth to make the enunciating, to enunciate clearly and articulate what you want to say isn't working right. And when that happens, you slur your speech. The tongue maybe isn't moving right, the mouth itself isn't moving right, the palate doesn't move right, and speech sounds slurred, like your mouth is full of marbles, or you're drunk, and you can't get the words out right. And that's typically due to weakness or coordination issues of part of the intrinsic part of the mouth. And typically, when someone starts to slur their speech, there'll be some facial movement. There's weakness there that usually is not just inside the mouth. And as opposed to aphasia, which is injury to the language areas, right? And that can be Broca's or Wernicke's or the things in between. And aphasia always is more worrisome to me than dysarthria. Dysarthria is bad too. The biggest thing I worry about when I see someone with dysarthria is that often if they can't enunciate clearly and they're slurring their speech, there's a good chance they can't swallow very safely either. And that's a pretty disabling problem. But language is hugely disabling. And so, and we talked about this already, but just to sort of talk about it again. So we have two types of aphasia, generally speaking. We have a comprehension aphasia and an expressive aphasia. And so we call this Wernicke's or Broca's because of the areas that are involved in the brain, Broca's area and Wernicke's area. And when you can't comprehend, people can't understand. And so the way I'll test that, honestly, is I'll say, without showing them or doing it, I'll say, show me two fingers, or open your mouth and stick out your tongue, right? And if you understand me, you think, one, that's a weird guy. And then two, you're and it's done. But there'll be a lot of people where they're really good at doing things that fit the situation. You come in and you say hi, and they say hi. And you're like, oh, this guy's great. He's fine. I'm gonna step out. But if you start asking them very directed questions, you begin to realize that they can't do some of these things. So open your mouth, stick out your tongue, show me two fingers. I'll purposely not mime them because people will see when they can't talk, they're looking for anything they can help understand what to do or what you want them to do. And so I do things like that. Expressive aphasia is a frustrating thing where people understand, fine, show me two fingers, stick your tongue, fine, no problem. Can you say the phrase, today is a sunny day? Silence, or they'll start saying words and they'll put in what are called paraphasic errors. Today is a yummy day. Today, they'll use words that maybe sound similar or sometimes even have similar meaning, but they're not the right words, and sort of substitute in the sentence the wrong thing. And so what I'll do when you can evaluate these patients or someone who has stroke symptoms, ask them to repeat a sentence. Okay, is it clear? Do they understand what you just asked them to do? Those are the questions that, sometimes they're like, oh, did you hear me? Stick out your tongue. If they heard you, they just can't figure it out. And then ask them to do something simple, right? Show me two fingers, stick out your tongue. Ask them to name an object. What's this? What am I wearing? It should be like, oh, you're so weird. It's a shirt. But if they are having a stroke, they can't say those things. Okay. So that's the F.A.S.T criteria. It is super annoying that the brain does everything, and that doesn't encompass every stroke that there is. And that's where we run into some of these problems sometimes, and that strokes are just bloody hard to nail down. They're hard in Tucson, they're hard at Harvard, they're hard at UCLA, they're hard everywhere. And this is something that we talk about a lot. And so other things that can happen, A common stroke symptom that we'll see is hemisensory loss, so loss of sensation on half your body. That happens from a very specific type of stroke in a part of the brain called the thalamus, which is, it's a very frequent spot to have a stroke in. And so people lose sensation on half their body. Sometimes when they lose sensation, they also lose the ability to coordinate the body very well, because part of how you control movement is by the feedback. Where's my hand in space? And you can't feel it, it's off. You can have sudden lower extremity weakness from a stroke. It sure can happen. Typically when we see just leg weakness, the first thing everyone's thinking about is, okay, what's going on with the spine? I would point out one of the nice ways to sort of differentiate between brain and spine is if it's unilateral on one side, we think brain and brainstem. If it's bilateral, we think the spine. And then sudden severe headache, right? So that's the subarachnoid hemorrhage, like someone came up behind you and hit you with a baseball bat. Typically the neck will be very stiff, because what ends up happening is the blood goes around the brain, and you have, interestingly, right, you have no pain receptors in your brain at all, right? So the Hannibal Lecter thing of cutting the brain, I guess you could do that and it wouldn't hurt. Where all your pain receptors are is in the meninges, the dura, around the brain. And so when you have a subarachnoid hemorrhage, that blood touching the meninges is what causes just extraordinarily bad pain. Your meninges actually go all the way down your spine and back up. So every time you bend your neck, you're stretching your meninges every time. And so people with subarachnoid hemorrhage will classically have exquisite neck pain. If you move the head back and forth, it hurts like bloody heck, because all the meninges is inflamed. And then I would point out, sudden confusion. Sudden confusion is, the emergency room doctor's, bane of their existence. It's sort of like, what? There's so many causes. What could it be? I'm always worried when I get called about sudden onset confusion that could be a stroke. Typically, the big thing that I worry about is the confusion really is more of a language issue, and they're not understanding what you're trying to tell them, or not able to speak themselves, or some combination, and that's really what the confusion is. There is a different entity called transient global amnesia, which is an interesting little turkey. I like it. I like TGA, transient global amnesia, because it tends to be the type of thing that people get better from, and that's always makes me happy. And so transient global amnesia, though, is different than anything else we described. And what ends up happening with TGA is you become suddenly unable to make new memories. Okay, so it'll be husband and wife, and they're in the car going to the mall to buy jeans. And all of a sudden, TGA hits the husband. Where are we going? We're going to the mall. What are you talking about? You went to buy jeans. Okay. 2 minutes, 30 seconds later, where are we going? Why are we in the car? Why are we going to the mall? Because you can't make new memories, and usually last for 6 hours, 2 to 6 hours, always less than 24 hours. And it's essentially, people repeat the same question over and over and over. They can talk. They can see, they can move everything just fine. It's just this sudden onset. It's not, and the beautiful thing about TGA is they get better. It's not a sign of dementia. And it's provoked by weird stuff, not the least of which is stress. But these are the patients where we will get them evaluated often for stroke. I have seen, in 18 years of practice, I've seen maybe 2 patients who presented with TGA and ended up having a stroke out of, hundreds of TGAs I've seen over the years. So it rarely can be, but almost always is not, and I look at it as a diagnosis. Okay, so we talked about it, right? Balance, sudden balance loss, sudden vision loss, both eyes, one eye, double vision, facial droop below the eye, smile, look at the dimple, arm weakness we talked about, and look for this, and kind of going down, speech problems, whether that's dysarthria or aphasia, and the last is time, okay? Super duper important, time. Well, this is not perfect. This is a good estimation, and this was a study done, a while ago now, at UCLA, where for the average moderate-sized stroke, so not small, not big, moderate-sized stroke, how many neurons do we lose, per second? 32,000 per minute, about 2 million. and how that ages your brain. We all lose a little bit of neurons, every day, unfortunately. But one stroke that's moderate size, in theory, advances your brain 36 years of age. That's not totally accurate, but the notion is there. Time is critical, right? If we're losing 2 million brain cells per second, and per stroke we've lost 1.2 billion brain cells, every minute, every hour, every second that we can get treatment in faster, there's less brain cells that are lost, and that's good for that patient. And so for ischemic stroke, which is 88% of strokes, the big drug that we use. Yeah.
So when their brain cells are lost, they're gone. Do they come back, or are they just gone?
When they're dead, they don't come back. When there is necrosis. What's interesting about the brain, though, is that when your neurons have different settings, right? Probably different than most other tissues in your brain, your body. And that is that when there's lack of blood flow, the neurons have essentially an off switch where they'll go into hibernation mode, and you'll have symptoms and they're not functioning, but the brain cells are still viable. And that's actually one of the things we look at often in hospitals, trying to figure out how much viable tissue there is. Something we're still not perfect at, to say the least. But and so it's hard to sometimes know. And going back, this number is different for every one of us in this room, and because it has to do with how your blood flow to your brain is. And there are some people where there's arteries where there's no backup, and there's some people who have really good collateral flow already in their brain, and so you block an artery, and instead of losing 2 million cells per minute, they could last 24 hours and do okay. And so it's interesting. There's a lot of variability here that has to do with your anatomy and genetics. But so once the brain cells are dead, they're dead. But there's lots of times where they're not dead, they're just not working, and they can come back online. The other thing I point out, and this is an important thing about stroke, is even when you lose brain from a stroke, your brain, no matter how old you are, no matter how young you are, no matter how old you are, your brain is plastic. It can make new connections and grow around those areas of damage, and essentially a healthy brain is more than enough to make up for the lost brain. Okay. Stroke treatment, we use Clotbuster. Okay, Clotbuster used to be a drug called tissue plasminogen activator, or TPA. TPA was a real pain in the neck because what we had to do is we had to calculate your weight, and then we gave you, and then we based the dose off of your weight. We gave 10% as a bolus up front, and then 90% we then dripped in over an hour. That's complicated. Who wants to do math when we're stressed out and trying to go fast and calculate all these things? And so what we started to use now is a drug called TNK, or tenecteplase, but we call it TNK. And TNK is essentially TPA, but it has a higher affinity to going to the clot. Okay, it has a higher affinity to fibrin, breaking up the clot, and it has a longer half-life in your body. So the beautiful thing about TNK is it's a one-time dose, and essentially it's a weight-based dose. It's a pizza cake, and we just inject it in, and we're done, and it's in, and it's doing its job. And so it makes it faster and easier to give. We typically will give this up to 4.5 hours after a stroke. That's generally speaking the limit. There is some data that's coming out suggesting longer time periods, 9 hours. But by and large, most places around the world still use 4.5 hours for TNK. If I give TNK to 100 people, okay, this is an important thing to sort of recognize, because we talk about TNK as the greatest thing ever, and it is. It's revolutionized. It is the first step we've had in revolutionizing stroke care. I've been in practice for about 18 years, and I've essentially grown up in a world of TNK, of TPA. But before my time, right, and maybe you guys had family that experienced this, if you came in with a stroke, you just got stuck in the back. There was no treatment. There was nothing. No one ran around to do anything for you. It was sort of like sticking in the back. If you survive, then we'll kind of get you going. So when TPA and TNK came along, we were jumping up and down for joy because there was something we could do that really made a difference. But I want to be cautious here. The difference is not as much as I wish it was. Okay, and so if I give TNK to 100 people, about 32, okay, a third, will get dramatically better. Those are my green people, okay? So not 50%, not 80%, 30%. And 67%, give or take, are pretty much the same. They're not any better, they're not any worse, you didn't hurt them, you didn't do anything bad. But some people can actually have complications from TNK, and that's bleeding, right? And bleeding, and when you give someone clot buster, you can bleed. And if you bleed into your brain, it's a catastrophe. And so this is the biggest thing that this is the biggest thing that makes everyone just stop and think twice and be careful about doing no harm. I have been relatively fortunate, but I have had patients who I know bled into their brain from the TPA that I gave them. And so you never want to do that. So this is sort of the thing that we're wrestling with when we're trying to give someone TNK. I don't know why I put that up twice. I probably had some good reason, but I forgot what it is. So I'm going to move on. So one good question I had, I feel like it was here one year, and the question was, well, if you want to get TNK so fast, why not just give it in the ambulance? Great idea. The problem with that, though, is that 9% of strokes, so the hemorrhage into the brain, they look exactly the same as the stroke from a blood clot. You can't tell the difference. I used to, when I was a resident and a fellow, I was always like, I can tell, I know what that's going to be by their blood pressure, by something. Never was right. And so that's the problem. You need a CAT scan of your head before we can give you TNK. Because if I give this guy TNK, he's dead. He's going to die. It's awful. Whereas this guy, I can save him. Now, there are mobile stroke units. And this is that of VT Houston. And these mobile stroke units have a CT scanner in them, and we'll have like a teleneurologist that can treat patients. And so just to give you an idea, it's about $1 million at the minimum to get that started. And I don't know, last I saw it was about $500,000 a year. Although the guy that was running the one up at Barrow in Phoenix, I can't remember what he told me the cost was during summertime to keep the AC on, to keep that thing running, but it was insane. And the problem I have with this movable stroke units out here is we're so spread out. Where does it go? There's other weird cost issues like who pays for the TPA. When you're in the hospital gets reimbursed. But what if who pays for it when you're out in the community? You don't have really a setup for that. So it's an interesting thing that we're working on to see how that might work. But that is an interesting idea. What we could use is a stroke helicopter. I would love to have a stroke helicopter that goes out to like Wilcox and Benson and all the different places. Although I'd love to see the helicopter that can handle a CAT scan. One of the most exciting and cool things that we've seen from stroke treatment has been the idea of thrombectomy. Just real quick, and over the years, stroke neurologists always wanted to be, and this is a joke, but I'll tell you this again. We always want to be as cool as cardiologists. They're not cool, I know. But because they can go in and put stents in and do all the stuff to the heart, and then, when it came to the brain, you could never do that. Well, it turns out that ultimately stenting in the brain and doing a lot of stuff that you do in the heart, it's just so much more complicated in the brain. The vessels themselves are different in the brain than they are anywhere else in the body. And the mechanisms of stroke are quite variable, whereas with a heart attack, it's the same thing every time. But one thing that we have found to be extraordinarily effective is clot removal. And we call that thrombectomy, right? A clot is a thrombus. And so a thrombectomy is where you can go into the groin, up into the brain, through the aorta, through the carotid, up into the brain, and literally suck the clot out. And this is an example of someone, this is their carotid artery coming up into the brain. This is the most important artery that supplies their face and their arm and language, potentially called the middle cerebral artery, and it's completely occluded. It's completely blocked off, a clot there. And so what they've got is they've got this cool, it's a very high-tech tool that basically is a catheter with a hole in it. It's like a hose. It's a hose they go up there, and they attach it to a vacuum. And they just put it right next to the clot, and they just turn the vacuum and run it for about a minute, and it'll suck the clot right out. And usually it's in the shape of the artery. It's the coolest thing, the cast of the artery. And you get results like this, where there's beautiful flow and all this brain is getting the flow that it needs. And so this is a game changer in that the number of people that are injured are very small. And this is, this is an interesting graph because it's better than it looks. So this is in people who have a stroke on top of getting TPA. So they've already had the last graph. On top of that, if you treat them with a thrombectomy, how many more people get better? And you get 34 out of 100 people that are dramatically better. And so this is, the thrombectomy is what we like the most. The problem is, I don't know, 20% of strokes, give or take. I should probably have that number better in my head. But 20% of strokes are caused by clots like this. So there are definitely a lot of strokes where people have bad symptoms and there isn't a big, huge clot. And that's one of the things that we're trying to figure out what to do with still. But with these strokes, man, we're really good. And there's a great New York Times article about they called it, EVT, which is essentially just thrombectomy, talking about this being, one of the revolutionary stroke treatments of our time. And it's true. I mean, these are the worst strokes, the worst of the worst. And people walk out of the hospital like nothing happened. And it's the type of stuff that, right, it's a beautiful thing. And so this is Dave Jenkins, this is in our cath lab. This is the type of device we use. It's a C-arm, and so it's an X-ray that they can adjust and move through controls to essentially look at the brain in any direction they need to sort of see what's going on. And I didn't put, interestingly, I didn't put this, one of the differences here is, so with TNK, the biggest thing we worry about is as the stroke is happening, right, the brain gets injured, but also the supporting cells that get injured, like the blood vessels. And so when the blood vessels get injured, then they start to weep and leak. And then you give TPA or TNK, you can cause that bleeding to get worse. So that's where that sort of 4.5 hours and kind of comes from as far as treatment goes, because we're worried if it's been longer than 4.5 hours, there's going to be leaky vessels and more risk. With thrombectomy, we treat patients up to 24 hours. And again, we're trying to sort of tailor a little bit. We try to pick patients where we can see that there's brain left to be saved, and we try to assess that based on a variety of different CAT scans that we use. But this is really great, and that's something that we can offer for much longer, especially some of those difficult strokes, those wake-up strokes, where people were asleep and had the stroke, which happens more often than we like, and then wakes up with the symptoms. Those are ones that we can still do this for. We're getting to the end, and it's been an hour. So I just want to shout out to TMC. I can't be more proud of being the stroke director at TMC. We're a comprehensive stroke center. We work with the Center for Neurosciences and Radiology Limited, and I think have a pretty awesome team. And if you asked me back in 2008 when I started, would we ever be a comprehensive stroke center or ever be awarded anything? I'd be like, I'm not sure if we can do that. And through everybody's really amazing hard work, we have been a top performer for American Heart and Stroke Association. I sent a new slide deck. So we even get with the guidelines Gold Plus, Elite, Target Elite, whatever one of the highest honors is, since before 2017 up until 2025, and I'm expecting us to get it again in 2026. With that, guys, and then as TMC, I think we do a great job with stroke. As a comprehensive stroke center, we do our best to work with our Southern Arizona hospitals, satellite hospitals. So Benson calls me all the time. I get CAT scans on my phone from Benson, from Northern Cochise and Wilcox, from Copper Queen, and from Mount Graham. And we do our best to take all those patients. Sometimes we're just cold dog on it and we can't. But as best we can, we take every one of those acute stroke patients and bring them here. To review, ischemic stroke, 88% of strokes, big deal. F.A.S.T is the acronym to remember. And if someone has a stroke, you want to seek care as fast as you can. If you call EMS, they call ahead, they bring you into the ED, and we're ready for you as opposed to coming by your own car. Any way you get in is okay by me, but EMS is the fastest way. Do not let the person you love who's having a stroke ignore their symptoms. It is human nature. I think we all do it. I'm fine. I'm not in any pain. My arm doesn't work, but I'm okay. Again, what happens a lot of times with stroke is that the person having a stroke just doesn't know it. They just don't get it. The part of your brain that's rational and thinking isn't working. The part of your body that's in charge of thinking isn't working right. And so they just don't know it. They don't recognize how bad it is. And then by the time they do, it's too late. The sooner we can implement treatment, the better. Get to a stroke center. I prefer TMC, but we're all okay. Time is brain, guys, so don't forget that. Okay, I'll open it up to questions. Okay.
Yes. So
Okay.
thank you, Dr. Teeple. So I did have some questions that came in. One was, is a TIA also a stroke?
Yeah. And so again, I never talk about TIA in this talk like maybe I should. So a TIA is a warning sign for a stroke. Okay. And so you can think of it like this. You have an ischemic stroke from a blood clot. The blood clot travels up to the brain, blocks an artery. That part of the brain stops working. And so you have symptoms. Whatever the part of the brain, that part of the brain is, whatever part of the body that part of the brain works on is not going to work right. Facial droop, weakness. But the brain cells aren't necessarily, injured permanently. They're just turned off because they're not getting oxygen. The difference between a TIA and a stroke is a stroke, the clot is there long enough to cause permanent damage. A TIA, the clot magically dissipates, is dissolved by the body, blood flow is restored, and the brain function comes back online. So if someone were to come into the hospital with an event that sounds like a TIA, typically our workup on those patients is to evaluate for major risk factors for stroke. What's your blood pressure? What's your cholesterol? What's your diabetes? Is your diabetes well controlled? Do you have AFib? Is your heart healthy? All those types of things are what we would really push for. And so a TIA is like angina is to a heart attack. A TIA is to a stroke.
Okay, right. So, and that also leads me to just share about our Stroke Prevention Saturday coming up on April 11th for folks.
April 11th, it's an awesome event. I couldn't be more proud to be a part of it. TMC opens up our Marshall Auditorium. You get assessed for your stroke risk factors, blood pressure, glucose, EKG. You'll see there'll be a provider there that can assess, your stroke risk factors and how well they're controlled. Usually we'll have other folks there like case management to review advanced directives, pharmacy to review medication lists. It's a really wonderful event, usually from 7 to noon.
Yes,
So
thank you. Yes. I have another question. Can you have a stroke from an unruptured aneurysm?
In theory, okay, so the answer to that, yeah, that's a good, tough question. The answer is, as a general rule, no. I think that 1 in a million, that in theory could happen if you had a very large aneurysm, you had a clot in there, and then that embolized up to the brain. But by and large, an unruptured aneurysm isn't really much of a risk factor for stroke and a much more of a risk factor for a subarachnoid hemorrhage.
Okay. Can certain medications increase your risk of stroke?
Can certain medication? So the biggest medication that I worry about with stroke risk, and it's an evolving area, but would be hormones, estrogen in particular, is something to be careful about. It's tough because a lot of the studies that we look at for stroke risk and estrogen are old studies done with horse estrogens that we don't use anymore, doses we don't use anymore. And so I think that this is an evolving area, but certainly women who have stroke risk factors like high blood pressure, diabetes, high cholesterol, we want to be really careful about use of estrogen, and that there may be a risk there with stroke, albeit very, very small. And it's usually a very individualized kind of question to sort of kind of work out. Things like NSAIDs, ibuprofen, can have a slight increased risk of causing clots. And so I use ibuprofen. But you want to try to use those things as sparingly as you can, and in a perfect world, not every day. All of these things, these are risks that are low, and you have to sort of decide what's right for your body. I'm miserable every day. I can't walk because the pain is so bad. It's, and life is better and worth living, frankly, if I can walk and get around. Okay, ibuprofen may be worthwhile then for you to take every day. But those would be ones that I would say have some risk. I'm sure there's other medications I'm not thinking of, but those are the two that kind of leap to mind.
Okay, so somebody just asked, if you used estrogen in the past, do you have a risk of stroke?
Nope.
Okay.
If you're not taking it, it's not a risk.
Okay, and then my last question is, if someone's taking a blood thinner, is a risk of ischemic stroke reduced?
And so the answer is yes. So, almost everybody with an ischemic stroke everybody, there would be very rare exceptions, who comes into the hospital for an evaluation should leave on a blood thinner. Now, I would point out aspirin is a blood thinner. It prevents your platelets from aggregating or clumping together, forming clots. So that thins out your blood. Aspirin is the most common blood thinner that we'll use. But Plavix is very common. Brilinta is something the cardiologists use, but that's effective. And then there are the more powerful anticoagulants that we use, Eliquis and Coumadin and Xarelto. Those all count. But at the very least, everyone should be on an aspirin, and we use those because they absolutely do reduce the risk of ischemic stroke. And you should be first, you'll be second, you'll be third.
Okay. One more. Is estrogen cream a risk?
I think estrogen cream. And so I point out, estrogen is something you should be careful about. I would point out they're getting better and better at lowering the dose of estrogen in general and mimicking natural estrogen in the body. That at the very least, I would just want you to have a good conversation with whoever's prescribing your estrogen. As far as estrogen goes, the cream is a non-issue. And that's such a local effect that doesn't have much systemic effect. I wouldn't be worried at all about the cream.
Okay. Dr. Teeple, I want to thank you so much for everything. I'm going to wrap up with our online audience, and I'll turn it over for you for any in-person questions. Thanks for being here today.
You bet.
Thanks again for joining us. We look forward to having you back. I did want to share with you also, as he mentioned, the Stroke Prevention Saturday is on April 11th at TMC to screen for your risk of stroke. If you're interested in registering for this, please give us a call at 520-324-1960. We do ask that everyone sort of register that is coming in for Stroke Prevention Saturday. So please go ahead and do that. In addition, we've got some classes coming up next week if you are interested. Navigating Brain Changes in Cancer is on Tuesday, March 17th at 11 a.m. That'll be with Carrie Reeves with our TMC Health Cancer Center. And in addition, also next week on Wednesday, March 18th is Decoding the Aging Brain, Normal Aging versus Cognitive Decline. And that'll be with Fran West. She's a nurse practitioner with Center for Neurosciences. If you're interested in either of these classes, the phone number again is 520-324-1960. Thanks again for joining us today. We look forward to seeing you again soon.